This ECG is fast and sharp. And no, it is not sinus tachycardia. Hello everyone, welcome to the Rhythm Files episode 2. Let's have a look at this case. A 64-year-old male was brought to the emergency with complaints of shortness of breath, palpitations, and burning sensation in the chest since 3 hours. He has a past history of COPD and was prescribed Deriphyllin tablets and azithromycin 2 days back for an LRTI. Patient is vitally unstable, pulse is 188 beats per minute, chest had bilateral inspiratory crackles and bronchi. A bedside ECG revealed the following. Okay, so try to find out the P wave here and the QRS duration as well. Overall, just take a look at the ECG in this one. We'll have a closer look as well to calculate the QRS duration and watch out for any STT changes. Observe this one closely and then we'll go for the characteristics. Right. So this is a narrow complex tachycardia because obviously the QRS duration is shortened. This occurs because the ventricular activation occurs faster since the rhythm is set by the re-entry focus and not the SA node. Secondly, there is ST depression due to subendocardial ischemia. Why? Because the coronary perfusion mainly occurs during the diastolic phase, and in tachycardia, the diastole duration has been reduced. Since subendocardial region is most susceptible to hypoxemia, it will lead to ST depression. Lastly, we'll see the hidden P waves that occur because the waves are so fast that the P wave hides in the QRS. So based on the findings, this is a case of AV nodal re-entry tachycardia. And since the patient is hemodynamically unstable, a synchronized cardioversion would be the preferred choice in this case. Now this is done by giving an initial power of 50 joules. And repeated attempts may be done at 100 to 200 joules if the first attempt fails. Now cardioversion is synchronized such that the shock is delivered on the R wave. This is done because at this point the entire myocardium is in a refractory state. An asynchronous shock can result in conversion into ventricular fibrillation that is known as R on T phenomenon. In this section, I have summarized the most commonly used and easily available drugs in most settings, and they are usually preferred in hemodynamically stable patients. The drug of choice here is adenosine, and it is given as a 6 mg IV rapid push as proximal to the heart as possible. It can be repeated at a dose of 12 mg after 1 to 2 minutes and again at an additional 12 mg after 1 to 2 minutes if there is still no results. Other drugs include metoprolol, verapamil, amiodarone, propranolol, digoxin, esmolol. In the comment section, I have added a link for management of supraventricular tachyarrhythmias by American Heart Association. Please like and follow. Thank you.